Runners have to qualify for this marathon. The lion's share of the doing and that's the only marathon I do.
Boston, April 15th, 2013. Game changer. What has been commonplace for years in other parts of the world has finally come to the United States. IED attacks on crowds in public places, car bombs, explosive mass casualty. This is what we've been waiting for, bracing since 9/11, and here it is. This is our new reality, what we must be absolutely prepared for, and certainly frames this program. I'm Dr. E. Reed Smith, Operational Medical Director for the Arlington County Fire Department and a board-certified emergency physician in the Northern Virginia region. Additionally, I am the co-founder and the current co-chairman for the Committee for Tactical Emergency Casualty Care. This series of lectures will cover the principles of tactical emergency casualty care for Washington, D.C. COG region fire and EMS personnel. Let me give you a scenario. Pick a metro station in DC. Let's say there's an explosion in that metro station as the train pulls up to a crowded platform during rush hour. This is an attack on public mass transit rail system that has been used multiple times in the past. Madrid, London, Moscow, and most recently in Russia again. In the confusion of the moment, the initial 911 calls will likely be unclear, and the initial dispatch will probably be for trouble unknown or fire or smoke in the station. The first arriving units report smoke coming from the station and injured people sitting outside. Victims report that as the train pulled into the crowded metro station, a blast occurred. Well, hopefully, pretty quickly, the initial first on scene will recognize that this is a coordinated IED attack on our metro system. Injured persons are being carried or assisted from the station by bystanders, and there are reports of multiple patients still in the station and on the platform and train in need of rescue. So, what are we supposed to do? So the question is, what is the traditional teaching on operational medical response for the reconnaissance and subsequent rescue of victims in scenarios where we have known wounded and an ongoing threat? Do we stand by, stage and wait for the all clear, scene safe for operations as we have always been taught? Is it scene safety first? Here's a picture of the Littleton, Colorado Fire Department during the Columbine shooting. Stage and wait. This is what they did for almost 4 hours after arriving on scene. Remember, the shooters were dead within 45 minutes, and yet for almost 4 hours, with wounded people inside needing medical care and rescue, for almost 4 hours, the Littleton Fire Department stood by. This is by no means a criticism of the Columbine response, because at the time, safe staging was what we thought was the right thing to do. Look at their faces. Look at the frustration. Those are heroes, anxious and chomping at the bit to go to work, yet they were forced to stand by. So in our scenario, are the first responders going to stand by? They know there are injured in need. They know the tactics and they know the risk. And I doubt they will actually just stand by with that knowledge. They are heroes and they're going to go to work. So, let's say the first responders decide to effect life rescue and enter the scene. Do they have the right equipment? Do they just do what they do on every routine medical call? You know, pull up, open the doors, get the stretcher out, grab the green bag, the red bag, the monitor, pile all this crap up on top of a stretcher and go into that scene. Are they going to go in like that here, after an IED explosion, with all this stuff piled on a stretcher and wait for that elevator to take them down? Are they carrying the right equipment? And when the first responders get to the side of the patient in this high-threat environment after an explosion, what are they supposed to do? There are multiple wounded and dead, and the potential for additional explosions or other threats to safety. Are they trained how to approach the patient in this high-threat scenario? How to appropriately change from their everyday medicine to a practice that is efficient and appropriate given the ongoing threat? So the question is there a gap in how civilian first responders both train to and respond to high-threat operational scenarios? The IED, the active shooter, any scenario with ongoing threat to provider and patient. Is there a gap in how we respond, both in medical tactics and medical actions? And the answer is, of course, absolutely. What we are discussing here is an operational gap. So why is this so important? Well, we've spent the last 15 to 20 years training to respond to weapons of mass destruction attacks against our citizens, training for sarin attacks, dirty bomb attacks, nuclear attacks. And yet, especially most recently, our enemy has a different focus. We have spent a lot of time training for sarin and organophosphate poisoning, millions of dollars an hour spent on atropine, on duodotes, and yet the threat has evolved to one that seemingly concentrates on bullets and bombs. Additionally, conventional everyday EMS has a different focus. We train for the common event. In medicine as a whole, Occam's razor, the rule that common things occur commonly, dictates our focus. We spend our training time preparing to treat common things. If a patient says they're having chest pain, you think pneumonia, heart attack, things like that. You don't think weird, once-in-a-lifetime fungal infections, right? Common things occur commonly. Our focus in fire EMS medical response has been on the common things. It has not been on these high-threat, active shooter, bombs and blast environment. Not only that, we as a nation have been at war now since 2001, 13 years. This is the longest war in the history of America. We have a multitude of information, evidence-based and proven techniques and procedures for the medical care of critically injured, wounded personnel in a combat environment. To me, that is medical knowledge that has been gleaned upon the blood of American soldiers, and we shouldn't lose that information. We need to bring it back to civilian medicine and to our fire and EMS operations. Here's part of the problem. When we look at the basis for training civilian EMS providers in trauma, the vast majority of what we deal with is blunt trauma, up to about 70%. Therefore, the focus of EMS trauma training is on blunt trauma. Look, you can go to any high-speed level 1 trauma center in the United States, whether it's Inova Fairfax, George Washington, whether it's Parkland in Dallas, or Jackson Memorial in Miami. It doesn't matter where it is. When those people get the report that there's a gunshot wound coming in, that there's an incident involving penetrating trauma or an explosion, they get all excited. They start getting their gowns on, pulling their stuff on. Come on, it's on, let's go. Because 70 to 80% of the time, it's blunt trauma. Penetrating and blast trauma is unique to us, even in places that see a lot of trauma. We just don't concentrate our training towards the ballistic and blast wounds nearly as much. We don't emphasize it because it is not as common, and that's part of our problem. For fire and EMS, we are in a new threat environment. The old threat environment was traditional WMD. It was sarin, dirty bombs, improvised nuclear devices. Here's the truth about traditional WMD. It's pretty damn hard to get your hands on some sarin, and when you do get your hands on some sarin, it's pretty hard to deliver it. When we talk about deploying a 1 kiloton nuke in Washington, D.C., when we talk about getting radiological material to deploy as a radiological IED, it's pretty hard to get and even harder to deliver. It's expensive. It requires training. It requires expertise. It requires a network of support. Could it happen? Of course. We can't ignore the threat, but we have to understand the actual likelihood and thus where in the priority list the traditional threat lies. This is our new threat environment. This is what we need to prepare for. Improvised explosives, high-velocity ballistics, lone wolf active shooters, dynamic, coordinated, small unit attacks. That is our new threat environment. We have to understand that in our new threat environment, the dispatch will often go out as a routine call. A dispatch involving an active shooter or IED attack could go out as something routine, a disturbance at a mall, trouble unknown at a school, smoke in a metro station. Or maybe we get dispatched as it actually happened, as a single shooting at a midnight movie showing in a theater in Aurora, Colorado. We have to be prepared to recognize the signs on scene, to recognize that we are not operating in a normal environment, that this is our new threat environment and we need to change our approach. Our new threat environment is characterized by a multilateral spectrum of potential threats. It is one or more bad guys that are oftentimes willing to die. It is military-style tactics and coordination. It is multi-capacity, high-velocity weapons, It is atypical threats, such as homemade IEDs, and the potential for toxic hazards, such as the use of CS gas in the Aurora Theater shooting. And then we have what's called austere conditions due to operational limitations and geography. What do I mean by that? What I mean is that our new threat environment, because of the risk to providers, creates conditions of austerity for the responders. Take a typical metro station where the platform is 100 feet underground. If an IED goes off on a train there, it doesn't matter that 100 feet above the platform, there's an army of apparatus and equipment and first responders. It doesn't matter that in this city, where there are multiple major trauma centers just minutes away, what matters to those responders 100 feet under the ground is what they're carrying on their backs, what they've been trained to do, and who their partners are. It is like providing care on the surface of the moon. That's what we mean by austere conditions. The new threat environment has significant impact on the delivery of pre-hospital medical care, and we need to understand this as we move forward in training for our response. The medical first responder in our new threat environment must maintain enhanced situational awareness while simultaneously providing appropriate and effective patient care. We have to change from what we currently do on typical medical calls, move away from things that are nice to do, and only do what must be done. For the average EMS call across the United States, quite honestly, we do a lot of stuff that's nice to do, but isn't necessary for life-saving. For example, we start a whole lot of IVs on EMS calls because we don't want to get yelled at by the triage nurse or the ER. But in our new threat environment, we have to change our approach. We have to change our focus and do only what is absolutely needed for life-saving until we can move to a safer place. It is important to point out that this is not an altered standard of care. What we need is a medical approach, a set of tools that allows the first responder to actually meet the standard of care in this high-threat environment, because right now they don't have that. There are multiple restrictions to care in this environment. There's a need for rapid mitigation of the ongoing threat. It could be a shooter, potential for explosive or secondary attacks, fire, structural collapse. It could be weather or ongoing traffic. So, in the midst of rescue, we need to understand that there is an ongoing threat, and the need for rapid mitigation must be balanced with the need for medical intervention. Additionally, supplies and equipment in this new environment are limited to only what initially is brought into the scene. This is not a place where we can call down to the engine from the 5th floor of an apartment building and ask them to bring up the CPAP. If you are on scene in a metro station, or at a bus bombing, or in the auditorium after a school shooting, you can't run back out to the rig to get what you forgot. It is only what you have on your back and we're capable of carrying in. Plus, there's limited manpower in the operational area because of the need to limit the number of personnel. We can't just have everybody come into the high-risk scene. Too much unnecessary risk. So we must limit the number of personnel actually operating on the scene. Finally, there's the potential for prolonged horizontal and vertical evacuation. So what do I mean by that? If you're injured in the cafeteria of a large high school, the fire department EMS resources and the casualty triage transport corridors are staged outside, somewhere in the parking lot or down the road, somewhere in a safe area. Let's say you're lying there bleeding from a femoral artery wound. It's going to take them time to get into where you are, then additional time to carry you down the hallway, outside the building, and down the street to where the ambulances are. That's a prolonged horizontal evacuation. And if we don't treat your wounds immediately, if we wait 10 to 15 to 20 minutes while we evacuate you to the triage and treatment corridor in the cold zone, you're going to die. So the potential for prolonged horizontal and vertical extraction of casualties exists. In our new threat environment, the casualty profile is shifted towards significant trauma, morbidity, and mortality. Expect multiple patients, each with multiple wounds, high-velocity ballistics, IED explosive with extensive fragmentation, amputations, all the things we saw in Boston. It is no longer just gangbanger A shoots gangbanger B with a gunshot wound or two. Your patient will have been blown up, burned, and have inhaled carbon monoxide and cyanide. They're eviscerated, they have bilateral amputations, and they've been shot 10 times. These are the patients in our new threat scenario. Delayed time to care. It might take 15 to 20 minutes just to get to the wounded, so they've been laying on the ground with uncontrolled severe injury for prolonged periods before we can start administering care. The potential for the very sick very significantly injured patients is real. There is also the potential for contamination and the use of chemicals or other things to increase the injury by the bad guys on scene. That is what we need to prepare for in our new threat environment. Multiple medically complicated victims, each with multiple severe wounds. The final impact of our new threat environment on medical care is that in this high threat environment, medical decision making must be based on risk-benefit assessment. We have to be able to say, what's the risk to the provider and the patient, what's the benefit to the patient, and balance that out. We need to have a framework where plans can be changed in real time based on what the risk is to balance the medical benefit versus the reality of the ongoing risk. And the care that we provide must be tailored to that relationship between the dynamic risk and the patient and the provider. So, stage and wait? Well, let's look at some data. We know for a fact that in trauma, time counts. Most of the data that I will be presenting is combat data, because at present, we do not have adequate civilian medical data in high-threat environments. We're working on getting it, but for now, we use military data as a surrogate. During military combat, we see that the majority of fatal combat injuries die within the first 30 minutes after injury. That's just common sense. Every minute with uncontrolled, life-threatening traumatic injury decreases your chance of survival. Essentially, the longer you lay there and bleed, the more likely you are going to die. We don't have too many hard and fast rules in medicine, but one of the hard and fast rules is that all bleeding stops eventually. Every minute with uncontrolled injury decreases your chance of survival. Ideally, we get to you and stop the bleeding before it stops on its own. Here's a picture of 5 liters of blood. That's roughly an average adult's entire blood volume. The other picture is half of that blood volume, 2.5 liters. If you lose 2.5 liters of blood through a femoral artery injury or some other massive bleed, 2.5 liters, that puts you into what we call irreversible shock. And irreversible shock, as I like to define it, it's in the name, is irreversible. It doesn't matter that we get your pulse back. It doesn't matter that we resuscitate you at this point. It doesn't matter because you've gone into an irreversible mechanism. And as I said, irreversible shock is irreversible. The case study for irreversible shock is Sean Taylor, the Washington Redskins free safety. Sean Taylor was the victim of a single gunshot wound to the leg that injured the femoral artery. The Miami EMS responders did a great job resuscitating him. He arrested in the field, and they got his heart back in the trauma bay. That night, the discussion on the news was, Sean Taylor's been shot in the leg, single gunshot wound. He's in critical care at Jackson Memorial. When's he gonna come back? Is he gonna lose his step? Is he not gonna be as fast? All these things. We all went to bed thinking Sean was gonna be okay. We wake up the next morning, and he's dead. And the collective thought across our region was, what the hell just happened? He has a single gunshot wound, and he had a heartbeat and a blood pressure last night? Why is he dead now? Well, because Sean went into irreversible shock, and irreversible shock is irreversible. This chart shows the percentage of combat fatalities from penetrating trauma as a function of time. So this is what used to happen on the battlefield. In the first 6 minutes after wounding, we lose approximately 20% of people. We call this irreversible death or instantaneous death. These represent the direct injuries to the head or the heart or the aorta. There's nothing we can do for these fatalities. Realistically, if you're going to die in the first 6 minutes, there's not much we can do for you. So we lose 20% in the first 6 minutes. Over the next hour, we lose roughly another 10%. Most of that is bleeding and airway obstruction. Over the next 6 hours, and then extended over the first 24 hours, this is where we start to see loss of life from shock. And then finally, from 24 to 72 hours, we lose a percentage from infections, complications of wounds, and other things like that. So, what do we do with this information? Well, in that first 6 minutes, it's very hard to do anything. Mostly, we do what we can to prevent the injury. We stop the bad guys from getting guns. We stop the bad guys from making bombs. We see something and say something. In that 6 minutes to an hour, honestly, this is the first aid basic life support. We can address that 10% by stopping the bleeding, opening the airway, and getting them to definitive care. Over the next 24 hours, really, that's where we administer advanced life support. We have to address shock at this point. And finally, over the 24 to 72 hour period, this is where our emergency department and surgery colleagues come in. And they use antibiotics and surgery and other things to prevent these complications. The first data set that really showed us that our approach to combat trauma was wrong was what is called the Wound Data and Munition Effectiveness Team, or the WDMET study. The WDMET study looked at a cohort of deaths, about 8,000 deaths out of Vietnam. In the military, everybody who is killed in combat gets an autopsy that identifies wounding pattern and cause of death. This does not occur in the civilian world, so it's data that the military has, but the civilian world does not. In this study, they were looking for how to make a better weapon. If we know how you die, we can make a better weapon. And they found it. But the sub-analysis also revealed some very interesting findings on the medical aspects. And this was the first study that showed the unique characteristics of battlefield trauma. Although this study was from the 70s, we've seen this pattern in studies again and again, all the way up to and including the War of Terror. Here's what they found. The greatest opportunity for life-saving intervention on the battlefield is early on. 90% of the deaths on the battlefield occurred prior to definitive care. 42% immediately, 26% within 5 minutes, 16% within 5 to 20 minutes. So, 42% of people on the battlefield died within 5 to 20 minutes of their injury. 42%. Some died 20 minutes to 2 hours later, and then some survived 2 to 6 hours until they could get to care, but subsequently died. And really, when you look at this data, what you see is that only 10% of people who died in this Vietnam cohort, only 10% of people received definitive care and subsequently died. What does that tell you? Early application of medical interventions saved lives. The summary results from the WDMET study were: the greatest benefit is achieved through a tactical configuration that puts the caregiver at the patient's side within a few seconds to minutes of wounding. It is not stage and wait until everything's safe, then bring the caregiver in. It is get the caregiver to the patient's side within a few seconds to minutes of wounding. That's what's going to save lives. Far forward placement of medical assets is life-saving. What's also interesting in this study, and what the military took forward, was that the study conclusions do not define the caregiver. It just says caregiver. It doesn't say ALS provider or EMT basic or trauma surgeon. It just says caregiver. This is another very interesting combat study. This one looked at data up to the 80s and early 90s, identifying the patterns of combat injuries and the distribution of wounds across multiple wars, some where the soldiers wore ballistic armor and some where the soldiers did not. And what we find across all wars, soldiers armored or unarmored, is that the vast majority, more than 1 out of every 2 penetrating ballistic and/or blast fragmentation wounds in combat are to the extremity. More than 1 out of every 2 injuries. Why is this? Who knows? Maybe because the limbs are hanging out there exposed. Maybe because there's more surface area on the extremities. Maybe because they're unprotected. But that pattern holds true. More than 1 out of every 2 injuries in combat is to the extremity. Hold on to that thought because it's important. This information is actually a landmark data set that comes from 2 different sources. One from Bellamy in 1984 and one from Arnold in 1978. It is a conglomeration of military autopsy data from multiple conflicts, not just Vietnam, but multiple conflicts. And it looks at the cause of death only. It doesn't look at wounding pattern. It doesn't look at other injuries, just what was listed at the autopsy as cause of death. Some interesting things come out of this. 25% of the deaths were surgically uncorrectable torso trauma. If a bullet tears your left ventricle apart, tears your intrathoracic aorta apart, there's nothing we can do. You could have a trauma team right next to you and it wouldn't help. 31% injury to the central nervous system. If you've taken significant ballistic trauma or blast trauma to the brain and your brain is completely disrupted or damaged, there's nothing we can do. But let's look at some important numbers on this chart. 9% exsanguination from an extremity wound. 9%. 58,000 people died in Vietnam. 58,000. So, if this pattern is extrapolated, 9% of those roughly 58,000 people died from bleeding from an extremity wound. That's roughly 5,200 people, 5,200 brothers, sons, uncles, friends, neighbors. 5,200 people died because no one had a tourniquet or was trained to use one. 1% airway obstruction. It's not very hard to manage the airway. 580 people, roughly 580 names on a wall in downtown DC because no one was taught to manage their airway. 5% tension pneumothorax. Not too hard to treat, but at least manage initially. 5% died because no one was trained to recognize, prioritize, or simply manage their pneumothorax. So, when we look at the military data set, 15% of military combat fatalities were readily treatable at the point of wounding. 9% exsanguination from a peripheral hemorrhage. 5% open tension pneumothorax. 1% airway obstruction. This is the signature wound from the War on Terror. It's a bilateral lower extremity amputation, and what you see in this picture is 2 field expedient tourniquets. In this case, they tried to do the right thing for this kid, but they did not have the right equipment. This was early on in the war, before the logistical need for tourniquets caught up to the battlefield. They did what they could do. It's interesting, the tourniquet here on the right leg failed, which is why they added another stick on the medial side. That stick was not added as an additional windlass, but was an apparent attempt to exert more pressure on the femoral artery, or at least that's what they thought, because the tourniquet was not working very well. 5 to 10% open or tension pneumothorax. How do we treat this? Well, we got to cover that hole and restore the integrity of the chest wall. 1% airway obstruction. In this case, the obstruction is caused by massive hemorrhage from the lingual artery in the tongue. So what we find from military data is that we can improve survival on the battlefield after penetrating and blast fragmentation injury through rapid application of simple, appropriate, stabilizing treatment at or near the site of wounding, plus expedient evacuation to the closest appropriate medical facility equals maximum survival rate for those injured. It's what we call point of wounding care. We want to treat you where you are wounded, stabilize the life threat before you move. Instead of moving you to medical care, we need to bring medical care to you. When we talk about point of wounding care, we have to look at the military because they're way ahead on this. As with most medical advances in trauma, the military develops it on the battlefield, and 10 to 15 years later, we get it in the civilian world. We're in that time frame now. The military's been doing point of wounding care for a while. Dr. Leray, Napoleon's surgeons started this. They would evacuate the wounded during the battle as opposed to just letting them lay there until after the battle when maybe someone from their family or someone else came for them. Dr. Jonathan Letterman, in the Battle of Antietam, was the first in the U.S. to employ ambulances for treatment and evacuation during the battle. And in World War II, of course, conscientious objectors became combat medics and did phenomenal things on the battlefield at the point of wounding. Vietnam is where the combat medic program and role really started to advance, especially in the special operations community. Many lives were saved. And now, with the War on Terror, everybody is a medic within the first 5 minutes of battle. Everybody is trained, starting with the 18-year-old who was riding a little yellow school bus 8 months ago. That kid has only been through a 1-day, 8-hour course, and he's carrying tourniquets, hemostatic bandages, airways, and yes, a big, big needle for chest decompression so he can treat himself or one of his buddies on the battlefield. The shift on the battlefield and the military paradigm came from the Navy Special Operations community. The Navy funded a study following the problems that occurred in several battles. The Battle of Mogadishu, Black Hawk Down, where multiple people died in a prolonged kind of evacuation care setting, and the Battle of Panama, the attack in Panama where the Navy SEALs attacked the airfield and sustained some injuries early on in the battle and then had trouble prioritizing tactical objectives versus administering medical care. That's what caused the Navy to start thinking about a change for medicine on the battlefield. Prior to the 1990s, combat medics were taught to manage battlefield injury using the civilian standard. There was no such thing as battlefield medicine. They taught medics the same way they taught EMTs and paramedics, even though they were going into battle and the environment was completely different. They taught the civilian standards, advanced trauma life support, and pre-hospital trauma life support to the medics who were deploying or going into combat. The problem is that advanced trauma life support is designed for a non-trauma physician working in a non-trauma hospital, which means inherently they have electricity, they have air conditioning, they have hot coffee, they have x-rays and CTs in a lab, and no one's trying to kill them. Then there's PHTLS, which certainly is a pre-hospital standard, but again, it assumes no ongoing threat due to combat, that the provider has lots of equipment, lots of personnel. And that's what we were training young 18 to 19-year-old battlefield medics, what we were sending them into battle with. Was that the best practice? Well, no, it certainly wasn't. The Navy study looked at the application of PHTLS and ATLS on the battlefield and concluded that ATLS and PHTLS lacked provisions for the combat environment. ATLS and PHTLS did not balance and allow for prioritization of the management of the casualties with the ongoing threat and the ongoing combat mission. They identified the trauma pattern as different in battle than it is on the highways of the United States, that the focus and approach of ATLS and PHTLS were wrong. There was no accounting for environmental factors such as dirt and cold and snow and other things associated with prolonged combat action. The long transportation times, the delays to definitive care, the fact that you can't get somebody out very quickly. PHTLS and ATLS did not address that. So the study conclusion was that the military needed a new paradigm for combat medicine. And in 1996, Dr. Frank Butler and a couple of others created what's called Tactical Combat Casualty Care. Very quickly, it was adopted for the special operations community, and roughly about 7 to 8 years ago, it was widely adopted by all deployable troops. So what is Tactical Combat Casualty Care? Well, simply, it is prioritization and application of medical care on the battlefield to address, not all causes, but the preventable causes of death while accounting for limitations and conditions of ongoing combat. Tactical Combat Casualty Care, or TCCC, only addresses the preventable causes of death, which I've already told you are hemorrhage from an extremity wound, airway obstruction or airway issues, and pneumothorax. But does it work? Well, of course it works. It's just a simple solution to a complex problem. In 2005, the casualty fatality rate, which means the number of battlefield wounded who died, was at 9.4%. In Vietnam, that number was 16%. In World War II, it was 19%. We are now below 10% casualty fatality rate on the battlefield for the first time in the history of mankind. And this study is from 2005. Through 2013, that number is well down below 7%. Why? Well, yes, the doctors are good, and the medicine is good, and the technology is good. Yes, we evacuate efficiently, and we bring definitive care far forward. But also, and most importantly, it is the fact that that 18-year-old who was on a yellow school bus 8 months ago is now carrying a tourniquet, hemostatic gauze, a needle, and is empowered to do something right at the point of wounding. That is where we are gaining the most life-saving. It's really that 18-year-old with minimal training and a few simple medical interventions that is keeping that casualty alive long enough to get to care. This is a study from the 75th Ranger Regiment. This study was published with data through 2010. The 75th Ranger Regiment was a unit that was involved in the heaviest fighting of the war in Iraq, Fallujah, and other battles. They were constantly in combat. These are tip-of-the-spear guys, and they fully integrated and emphasized TCCC training from command level down prior to their deployment. Over their 7 years of combat, they had very, very high wounding rates because of their job, but they were down to a 7.6% case fatality rate. Unbelievable. And of those 7.6%, only 3% were considered preventable, down from 15% from the Vietnam dataset I showed you earlier. In OIF-OEF, Operation Iraqi Freedom, Operation Enduring Freedom, we are now at 2 to 3% killed in action from bleeding to death from extremity wounds. Remember, in the Vietnam data I showed you, it was 9%. So with the widespread emphasis on point of wounding care, we've gotten down to 2 to 3% killed in action from bleeding to death from extremity wounds. We've gone from 5% from tension or open pneumothorax down to less than 3%. And we're still roughly at 1% from airway obstruction. But what they're seeing are airway issues that are much more complex than they were earlier on in the war. This is the power of TECC, of Tactical Combat Casualty Care. It is evidence-based. It is best practice-based. It is a decade plus of data with continuing evidence to support these guidelines. It's well known. It's well supported throughout the military, and it's now being brought back to civilian, fire, EMS, and police, mostly by returning veterans, because it seems to be a good idea. Here's my question, and here's what I pose to you. Should tactical combat casualty care be a new civilian paradigm? Well, the reality is that current fire EMS operational medical response is inadequate for atypical emergencies from a medical perspective. And it would seem that if it works on the battlefield, it should work for us, right? But when you think about it, battlefield guidelines don't really translate exactly to civilian operations. Applying military lessons en route, en bloc to civilian high-threat medical pre-hospital care is a little bit of what we call round peg, square hole. Tactical combat casualty care was written for and based on evidence that was gleaned from an overall young and healthy 18 to 45-year-old military combat population. They're not obese. They don't have diabetes. They don't take aspirin. They don't have asthma. They don't take Coumadin. They're not pregnant. They're not elderly, and they're not kids. It was written for the military combatant treating the military population in the combat environment, which means that they work under military laws, military liability, military rules. And when you look at the military application on the battlefield and bring it back to civilians without changing it, it has the same fundamental inadequacies, albeit in reverse, of applying civilian ATLS and PHTLS to the combat environment. Combat doctrine does not account for the civilian specificities. Here are some of the differences, and it's just common sense. From jurisdiction to jurisdiction, region to region, and state to state, we have different scope of practice, protocols, operations, cultures, and liability. The military doesn't. They have one scope of practice, one set of protocols, and they can do it across the board. We can't do that. We have a much wider patient population. We have pediatrics and geriatrics and special needs. We have pregnant patients and handicapped patients. We have patients with heart disease, strokes, on Coumadin and aspirin. They don't have that. The availability of transport assets and barriers to evacuation are different. For us as a whole, once you get outside of the immediate area of operations, no one's trying to kill you. In the military, bad guys are trying to kill them all the way back to their base. We don't have that problem. The baseline health of the population is a lot worse for civilians. Underlying medical problems like asthma and diabetes keeps you from deploying in the military, so they are unaccounted for in the TECC doctrine. Wounding patterns are different. Chronic medication use, even as simple as aspirin. If you take aspirin or Motrin in the military, you're not allowed to be in the deployable population. And then equipment selection. How they choose equipment, how they get equipment, and how they use equipment is different than we do. The military can dictate what all providers in all areas of operations and services have to use. We can't do that. For us, it alters jurisdiction by jurisdiction, agency by agency. Plus, military language is different than civilian language. We need a framework that utilizes common operating language across all disciplines, including law enforcement, fire and EMS, hospitals, and it must be acceptable to all disciplines and applications. A couple of years ago, I went to Chief Schwartz in Arlington County and said that we were going to implement a new medical response paradigm from the military. Well, Chief, I said, in the first phase, we're going to have firefighters doing care under fire. He looked at me. You're crazy, Doc. We're never going to be voluntarily shot at, and we're never going to do that. But Chief, the doctrine says the best medicine is fire superiority, and that we should return fire and take cover. You can see the issues with military language. However, if we simply change the language to more civilian terms, not care under fire, but direct threat care, well, now that's all encompassing. Now it starts to make sense from a civilian perspective. TECC is currently being taught to civilians by PHTLS, and there's certainly civilians in the National Capital Region that have taken TECC. Some may think that TECC is the solution and that there's no need to recreate the wheel. However, ironically, the PHTLS TECC course that's being taught to civilians admits it is not for civilians. This is one of the last slides of the PHTLS TECC introduction. This is the actual slide. Designed for combat, not designed for civilian trauma. So, in 2005, people began looking at transitioning TECC into a civilian-appropriate format. In 2008, the George Washington University and Arlington County Fire Department coined the term Tactical Emergency Casualty Care. We changed combat to emergency. Emergency is a civilian term. Combat is a military term. Tactical Emergency Casualty Care. It is now a 501(c) established committee of civilian pre-hospital experts. It is nonprofit. It is non-proprietary. Everything is open and shared with everybody. So what is TECC, Tactical Emergency Casualty Care? TECC is civilian, threat-based medical care guidelines. It is a new high-threat medical care framework based upon the military dogma of tactical combat casualty care, but adapted to allow for civilian language, civilian protocols, civilian population, civilian scope of practice, and our operational constraints. It is important to understand for all of you out there who have your TECC card, TECC is not in competition with TECC. It is the evolution of TECC into the civilian realm. TECC, Tactical Emergency Casualty Care, is civilian. TCCC, Tactical Combat Casualty Care, is military. It is the same thing translated and evolved into civilian operations. It's what we call same but different. We consider Tactical Emergency Casualty Care to be a set of bricks. The military Tactical Combat Casualty Care is dogma, which means you cannot change it to meet your operational constraints. Everyone follows it to the letter of the law. We cannot do that. So TECC is designed to allow for different agency-specific adaptations, given the protocols and the scope of practice between different agencies and providers. The guidelines are essentially a set of bricks. Take the bricks that work for your agency, your protocol, your scope of practice, and build a high-threat medical response program. Just make sure you use this set of bricks. Ultimately, the building that I built in Arlington with these bricks will be a bit different from the one in Fairfax, or maybe the one in Prince George's County or in DC, but it's the same bricks. The committee now has a set of pediatric guidelines that are the first set of guidelines for kids in high-threat environments. We emphasize triage, not only for priority, but for priority and destination. We have emphasis on civilian-specific conditions, such as smoke inhalation, things that the military isn't concerned about. And TECC is an all-hazards approach, just like we are an all-hazards fire and EMS service. TECC principles can be applied to any operational scenario where there is an ongoing threat. The goals of TECC is to establish a medical care framework that balances the threat, the civilian scope of practice, the differences in civilian population, the medical equipment limits, and variable resources for all atypical emergencies and mass casualties. To provide aggressive forward deployment and principles for point of wounding care in high threat and mass casualty environments. To provide care guidelines and account for the ongoing threat in operations and minimize the provider and patient risk while maximizing patient benefit. Is it only for medical personnel? Absolutely not. TECC can be taught to anybody because anybody can be a first responder. It should be taught to school teachers. It should be taught to CERT teams. Patrol officers are a great resource, and we've seen this before. Patrol officers empowered and taught to do some very simple, basic life-saving stuff can make a difference. This is the very basic medical kit that Pima County, Arizona sheriffs carried when Gabby Giffords was shot. And in that interim, between when they first got on scene, tactically secured the scene, and before fire and EMS began operations, the patrol officers were able to initiate care on the wounded. Remember, every drop of blood counts. We have an ongoing program right now in the region that has trained approximately 4,000 Northern Virginia patrol officers in officer-appropriate level TECC care, so they understand their role in the first 5 minutes and the continuum of care. Montgomery County and Prince George's County are looking at the same thing. DC is looking at the same thing. The word tactical is in the name. And there are a lot of people out there who think if it says tactical, it's only for law enforcement or for SWAT medics out there. The truth is, we use tactics every day. How you decide to lay out, how you approach a structure fire, where do you stage your vehicle, how do you evacuate that overweight guy on the 5th floor far away from the elevator when the elevator is out and the lights are out in the stairs. Those are tactics. Tactics means operational considerations. So we use the word tactical to mean operational decisions that both affect medicine and operations. What TECC is, it's civilian driven, it's civilian appropriate, it's multi-agency, multi-specialty. It's appropriate for use in any scenario where there's significant ongoing operational risk to providers and patients. It's vetted, it's evolving, and it's a great venue for future research. TECC is not rigid care protocols. Again, it is not dogma. It is not a formalized training program. We're trying to teach you to fish. We don't want to give you a fish. We're going to teach you how to fish and allow you to build your own agency high-threat medical response program. It is not law enforcement specific. It is across the board all first responders, and it's not only for tactical medics working in law enforcement settings. TECC is situation driven. Tactical emergency casualty care is a framework that allows the provider to prioritize and balance the operational and medical priorities. Overall, TECC is applied in 3 phases defined by the relationship between the provider and the threat. The threat is not defined in the guidelines. It is defined by you on scene. It is your perception of what the threat is to you and the patient, and that perception of threat dictates what you do. There are 3 phases of care in TECC defined by the threat: direct threat care, indirect threat care, and evacuation care. So, in conclusion with TECC, our goal with TECC is to identify and treat those casualties with preventable causes of death. Remember, we're concentrating only on the preventable causes of death, allowing the victim to stay alive long enough to get to care. Because if they don't arrive alive, there is nothing we can do for them in our trauma centers. It is evidence-based. It's best practice-based for use by all levels of providers, from the civilian bystander to the first responder, to the EMT basic, to the EMT intermediate, to the EMT paramedic, to the advanced practice paramedic, to the physician. It's a starting point in an ongoing process. We constantly evaluate evidence and constantly update recommendations based on the most recent and most relevant evidence. And it's value added. Because if you understand that massive bleeding rapidly kills you, and someone gets an amputated leg in a rollover MVC, you're going to recognize that. You're going to know how to use the equipment. You're going to know how to prioritize that care. So where should TECC principles be applied? Absolutely, it has applications in active shooter. Point of wounding care, prioritization for what only needs to be done in a high threat environment. Let's stabilize the 3 things we know that are going to kill them and get them out of the building. Response to explosives. Obviously high threat. We saw it in Boston. We don't know if there are secondary devices. The potential for secondary attacks, tertiary attacks. Absolutely, this is a high threat environment. Let's use TECC there. And certainly, patrol officer down. Patrol officers do a dangerous job, often isolated and alone. Patrol officers need to be empowered to take care of each other and take care of themselves. Of course, our SWAT tactical guys, absolutely those guys need it as well. TECC rescue. Let me tell you something. In a confined space, a high line, a trench, that's a dangerous place to be. So let's pare down the medical treatment and make it as minimal as possible, defining only what is absolutely needed for life saving. Then, once they get out of the trench, once we get them out of that confined space, then we can go ahead and treat them in a full scope of standard EMS. Wilderness. We don't have a lot of wilderness around here, but we have some. Wilderness and austere settings absolutely are high risk, and the principles apply here. Mass casualty. Absolutely. Look at this picture of a bus turned over. We've got ongoing traffic. The weather is bad. Is this thing going to slide? How are we shoring it? People are injured, overwhelming our resources. Let's prioritize to only what needs to be done right there until we can move them to an area that's safer. There are absolutely implications in all mass casualty for high threat medicine. Well, that's it for the introduction. The rest of the training will involve the 3 phases of care and the actual guidelines. Good luck and be safe.